Let's go ahead and get started. Welcome everyone to the weekly ArMA COVID-19 virtual town hall. We'd like to thank all of you for taking time out of your evening to join us for another great and informative event tonight. A little bit of Zoom housekeeping. This is a professional environment and we ask that everyone remain respectful towards all participants. This webinar is being recorded and will be published for others to view at a later date. You can see and hear us, but we cannot see or hear you. The webinar is best accessed through a computer and utilizing the features at the bottom bar of your Zoom screen. That includes the Q&A function where you can submit questions throughout tonight's event. We ask that you do please submit your questions through the Q&A function and not through the chat function. And the best viewing option is to fit it to the window. Your moderators for tonight are myself, Damian Johnson, Director of Communications here at ArMA, as well as I'm joined by Megan McCabe, ArMA's Deputy Director of Government Relations. Our panelists tonight include Dr. Robert Weinstein from the Southwest Telehealth Resource Center, Dr. Ross Goldberg, ArMA's current president, Juliana Stanley, ArMA's Director of Practice Support, and Steve Barclay, ArMA's lobbyist. And at this time, I'm going to go ahead and turn it over to Dr. Goldberg, who's going to give a quick update from ArMA.
Good evening. Thank you all for coming again. As always, we appreciate everyone taking the time, and I thank our panelists as well. Again, it's never boring here. I know it's been a very interesting weekend as you can watch the news and see what's going on. We're going to wait and see how things turn out. We are in contact with all the state officials, working heavily on all areas. Again, always, if you need anything or need to let us know of something, please let us know. We're here to help. We continue to advocate for our profession, our members, our patients, and continue how to figure out how things are going during this crazy time. But we appreciate everyone's support as always. And with that, I'm going to turn it over to our main speaker, talk about telemedicine. Now, you heard some from the insurance side. Now we get to the meat of it, getting really how it can be helpful for you and what you can do. So, Dr. Weinstein, it's all yours, please.
Okay. Mike's going to hook me in. Thank you very much. Let's see, we can come right up here. Okay. Dr. Ronald Weinstein. Okay, Ronald Weinstein, named after a movie star named Ronald Coleman. Okay, first of all, thank you for the invitation. This is really a great pleasure for me. I've an enormous admiration for ArMA, and certainly our programs are looking forward to do more with ArMA now that we're really into training on a very large scale for reasons that I'll talk about in a moment, some of which might be a surprise to you. Before I do that, let me just tell you where we are. We're not in a virtual world. We're in Tucson, although people think it's a virtual world here. We see an education building, brand new education building that has 35,000 square feet of simulation space. So if patients can't go out on the wards, we can simulate a lot of things here. And also do a lot of joint work with telemedicine and simulation. And then the building back here with the dark windows, that's the library and the Arizona Telemedicine Program and the Southwest Telehealth Resource Center on the bottom floor of that building. And then our brand new hospitals over here. And then our brand new precision research building is over here. So as in downtown Phoenix, there's a new campus. This is a little bit smaller, but it pretty much duplicates what those from Phoenix are very familiar with. And the Arizona Telemedicine Program is in both Tucson and Phoenix. So I'm the founding director of the Arizona Telemedicine Program. Now, to set up the content of what I'd like to talk about this evening, I want to make a few orientation remarks. And a lot of this would be surprising to particularly the healthcare providers on the line, because you know what they're going to say is, where's this been all my life? And the answer is, it's been hidden. And this is a tale of two cities, because telemedicine was developed in the late 60s and 70s. And by 1979 or 80, there were 10,000 papers. But because of US government regulations, regulatory policies, and so forth, the actual implementation as an educational component was delayed close to 40 years. So it took COVID-19 to shake up the medical education industry and begin for the very first time, just over the last 2 or 3 months, to add telemedicine rotations. And therefore, the net result is today a graduating medical student who may catch it on the way coming out of the door, or a professor, a full professor who's been around for 30, 35 years, they basically know about the same amount about telemedicine, which is it works well, easily implemented in practices, but there's so many more opportunities once you bring that to your office practice. And that's simply not widely known. And we depend on the training programs that come out of Arizona Telemedicine Program, Southwest TRC, National TRCs, to begin to educate physicians on what those opportunities might be. And begin to educate physicians on what it's really going to look like in the fourth industrial revolution as we begin to get this fusion of artificial intelligence and robotics and automation and telehealth as a way of practicing medicine down the road. So it's a gateway into future technologies, and I'm very optimistic about it. I think tremendous opportunities for physicians. So I'm going to start out with a couple of orientation remarks related to what I was just talking about, and hopefully you'll see why that's interesting and important. First of all, I do want to mention that, let's see, I have to get my, Mike, I have to get my, okay. It's blocked on my screen, but hopefully you can see in the upper left-hand corner. Mike is going to help me move that down. Okay, I want to mention the fact that there's a key legislator who really jump-started telemedicine in Arizona, and that's Representative Bob Burns. And Burns joined the legislature in around 1988, almost immediately became head of the Appropriations Committee, decided in the early 1990s that telemedicine would be right for Arizona. And this is at a time when the Western Governors Association published a key report on what was blocking telemedicine from happening. And it always comes down to policy, regulation, reimbursement, and culture. And he said, we just have to get beyond that point. Now, he termed out of the, he started the funding for the telemedicine program, and he and I had a lot in common, which we don't have to go into, but we basically partnered and have worked together for the last 23 years in promoting telemedicine in Arizona and regionally and nationally. So he's been a great partner for me. So anyway, he's head of appropriations, and then he turns out, gets in the Senate, day number 1, gets elected head of the Appropriations Committee in the Senate, goes all the way to 7th and 8th year when he becomes president of the Senate, terms out, runs for Corporation Commission, gets elected after a couple of terms, becomes the chairman. And so he's been my partner. And he and I together created what's called the Arizona Telemedicine Council, which meets quarterly on the state capitol campus and has 39 blue ribbon members and has done wonders to promote telemedicine in this region. Orientation comments. Okay, nobody learned about telemedicine in medical school. Really? Well, telemedicine was very activated at the Massachusetts General Hospital in 1968. I happened to be a resident there at the time, resident in pathology, and got drawn into the original practice. And as a point in fact, was, as far as we know, the first resident to actually do a residency or a rotation in telemedicine. And so this was a program that linked the Logan Airport to the Mass General, and walk-in clinic was supported by telemedicine, and was very successful and ran for years. And people flocked there from around the world and cloned hundreds of telemedicine programs around the world, including a very large one that was in Arizona in the early 1970s called StartBack on the Tohono Reservation. And that was a joint project of NASA and the University of Arizona and different governmental agencies, and was very successful. But what happened was at the end of the 1970s, although there were 10,000 publications, the National Science Foundation decided not to support the original 24 projects, and the United States went black. went dead with respect to telemedicine. It kept developing in Canada, it kept developing in England, it kept developing in Australia, but it died in Arizona for the United States for all practical purposes. So people who might have gone to medical school in the 1970s are probably all emeritus professors except for me. I think that since they learned about telemedicine, but it blanked out and continued to be blanked out into curriculum in most medical schools in the United States until 2 months ago, which is a pretty remarkable story. Now, I might mention in passing the other student who was involved in the program at the Mass General, the first medical student was Michael Crichton, who as a senior at Harvard Medical School wrote Andromeda Strain, bestseller, Jurassic Park and so forth. But he also wrote another book, which was a nonfiction book called 5 Patients, and it described his encounters as a medical student with a telemedicine patient and included a decision support system where a computer interviewed a patient to take the history. And that was fully packaged by the time that book got published in 1969. And you can still buy it on eBay for $4, and it's an interesting read. So nobody learned it at medical school. So when we have this challenge as educational institutions, who are we going to educate? And the answer is all physicians, but all healthcare workers as well. Because telemedicine is basically new as an educational component. Today, telemedicine practices are easy to start. Ross was telling me about his success story in his practice, which I was just delighted to hear. And hopefully we'll get his partner to come at the next Arizona telemedicine program and tell us about that startup. But I think it's safe to say there was a national program this weekend, the future after COVID-19. And they were talking to Eric Schmidt, who was recently the chairman of Google and Alphabet. And they said, what's going to be the greatest legacy of this? And he says, it's going to be telemedicine and telehealth. And he said, a recent survey they did showed that starting in March of 2020, today 60% of practices in the United States have incorporated telemedicine. And of course, we heard about that last week from the CEO of Blue Cross Blue Shield and her excellent presentations where she said April to April, they've gone up 3,200%, 32 times the amount of activity. And we're hearing that from a number of the big service companies. So it can't be that hard to start, but a telemedicine practice that starts may be very adequate for daily uses, but it opens huge gateways to other programs and opportunities for practices. And that's still largely unknown to the medical world and the other health professions. So that's part of what our charge is, to actually begin to actually tell people where the opportunities are and create the roadmaps. Okay, roadmaps for telemedicine startups are readily available. And again, I'll describe a number of training programs that actually give you those roadmaps. And the thing of it is, it's not hard. It's not hard to go down the roadmap. I would say that I can teach anybody in the health professions 80% of what's really worth knowing today in a 6 or 7 hour course. And the people who take the courses come out and say, we were amazed how much granularity is to it and the opportunities that exist. And we've had people through the years have taken these courses 2 or 3 times. And because these things keep mushrooming. So the roadmaps for telemedicine startups are readily available, particularly to anybody who's done this. This is the hardest part of it, to say we're going to do it. And certainly most practices have already succeeded in doing that. Okay, well, the first stage in telemedicine, that first 10 or 15 years, that's already been celebrated by various pioneers in telemedicine programs. I got involved in telepathology. Full disclosure, I'm a pathologist. I got involved because of a national crisis at the National Cancer Institute because of inter-observer variability among pathologists on diagnosing cases who were going on clinical trials. That's a long sentence with a lot of words in it. What it would basically mean is a bunch of experts couldn't agree on the diagnosis, and we had to trash a lot of the cases after studies were done. So we actually got through 17 protocols: superficial disease, deep disease, metastatic disease, chemotherapy, radiotherapy. And a couple of them we couldn't even publish because of diagnostic errors. And the question is, how could we render the diagnosis upfront before the patient actually went on a clinical trial? And I happened to be the head. I was the chief referee for these cases and was running a central path lab for the dozen hospitals around the country who were participating. And finally, out of frustration, I said, I'd be better off replacing you all with robotic microscopes. And then I invented it and patented it and started a company. Today, that's a $1 billion industry. But that's how I got into it. So here I'm back in the library of the Mass General Path Department celebrating the 50th year of my introduction to the field. Okay, well, what were they doing back there? Could have been called tele-everything. And the Mass General program, I think, published a couple of papers with 4,000 consecutive cases. Teledermatology, what did they discover there? They discovered you don't need color to do dermatology. That'll shock physicians. But did you know 7% of physicians are colorblind? Probably not. 7% of pathologists are colorblind. Maybe that experiment's been done by nature. Telecardiology, well, they took the technology right out of the space program. And so basically Lockheed Space Missile Companies was the contractor there, was the contractor in Arizona for StarPack that I mentioned, was the contractor for a Phelps Dodge telemedicine group in the Southwest, practice in the Southwest and place New Mexico that went on for 25 years till the copper prices went down. Teleinfectious disease, psychiatry, pulmonology, radiology. They have exactly telepathology, but they have what was called teleclinical microscopy. That was our involvement, and a large number of other things. And these were already evolving into networks in New England by 1971 or 72. And when we go back and look at the studies, frankly, the diagnostic accuracy was the same as it is today. It was very, very high. And the technologies were perfectly adequate using NTSC television. So long history of successes, and certain fields really thrived, particularly behavioral health. Now, behavioral health has been a huge one in Arizona. Up till very recently, there was a sister program started by Representative Burns in 1996 to do telemental health in the northern half of Arizona. And for years, almost all Medicaid patients who had psychiatry, mental health diagnosis were treated by telemedicine. And 2 years ago, 70,000 cases were done just in the northern part of Arizona for psychiatry. And there are whole networks of patients around our state who get their mental health services by telepsychiatry. Teleradiology, I'll get to in a few minutes. That also is an important Arizona story. Okay, well, let's look at the growth of the field. And the name of the op-ed piece I'm writing from one of the journals. But telemedicine sea of change, is it a surge or a tsunami? And we can pick up on that in the questions and answers if you're interested. But in 1995, it was estimated that there were nationally 100,000 to 250,000 cases. And most of those were prisoners in Texas, where there were 2 large telemedicine networks, one for the western half of the state, one for the eastern half of the state. Now, if you take that number and look at it increasing by 25 to 30% per year, you would expect that there would be 15 million cases in 2017, and that's just about what the estimate was by the American Telemedicine Association. And if you increase that by 25 or 30% a year, you end up with 37 to 39 million cases in 2020, which looked like that's where we were going in January. But then this is what happened. I got a phone call from AARP so they could quote me on a story on an estimate of what the number of cases would be for the year. And I said, well, I'm hearing rumors that a lot of programs are getting started. This was around the 10th of March. So I very humbly, I suppose, if that's possible, I said, I think it'd be about 250 million cases by 2030. And then around the 15th of April, they have a fact checker for the ARP Bulletin. I don't know if any of you are old enough to get that, but for the ARP Bulletin, they have a fact checker who called me up from DC and he said, I want to check up on that number. And I said, I don't know about that. I think it's going to be a lot, and began doing the calculations and basically predicted that as a point in fact, we would have 1 billion cases by the end of 2020 annualized. And I think that's probably a very good number. Now, part of that's an artifact because telephonies, we're beginning to use telephone calls as acceptable. And whereas there's this big concern of, is it going to be by telephone or is it going to be by video? And the answer is, boy, if you're in a training center like ours, it's by text messaging. And as a pointed fact, 3 years ago, the CEO of Kaiser North, which would be the San Francisco area, said that half of their interactions between doctors and patients was by text messaging, or was by telemedicine. And so 110 million interactions, 55 million being by telemedicine. And it turned out he was really talking about text messaging. So that's come mainstream. That's a big problem for us because of HIPAA and so forth. There are portals on Cerner and Epic for doing secure text messaging. But when we get that billion case, a little bit of that is how we're really going to define this in the future. And that's going to be a continuing conversation. Well, why? Why did the surge happen? And actually, Steve can straighten me out on this later. If I'm getting into something that involves legal and the law, I am immediately over my head. So you can straighten me out. But this is what I learned from our expert on a policy. Why? And the answer was waivers, right? Presidential order, and the waivers took place. And almost all of the things that we have been lobbying for years, certainly when I was president of the American Telemedicine Association, back and forth to Washington lobbying for, there was this whole long wish list, and they were virtually all implemented overnight in the beginning of March. And so the next slide sort of gives a sense of how those changes turned out to be. Here, the only area where Medicare discriminated for many, many years was against urban patients doing telemedicine. It's the only service that was restricted to rural for years and years, right? So rural had it before, but urban didn't. Well, overnight that changed, right? All of a sudden you could do urban. All of a sudden you could do it from people's homes. And you could do it from people's homes without having a case presenter for the first time. And you could do it from people's homes with anything that showed a picture. So smartphones became the workstation of choice nationally in almost no time at all in patients' homes. You could do it at SNFs, but you couldn't do most nursing home settings. But all of a sudden that became, we're talking about CMS Medicare reimbursement on this chart, right? Nursing homes. Interstate licensure still depends on the states, but it got very, very legal. Today, if I have an Arizona license and my snowbird goes back to Minnesota, I can see that patient by telemedicine more likely than not. Now, that's been existed in the VA for a long time, because the minute you walk into one of the 154 VA hospitals, you then can do telemedicine in any VA hospital in the world, right? But now that became a standard of care. Number of cases a year, I said 39 million pre, I said a billion, and of course, the billion is now. That's the rate that is taking place. And we don't hear about a lot of bad outcomes. We don't hear about unhappy patients. Quite the opposite. We hear a lot about patients who say, boy, it's really the way I want to do it. It certainly doesn't work for everything. And I certainly know practitioners who would prefer to do a lot of things in person. And it's not a panacea, but it's certainly new, and it's a new way of practicing, and it's going to accommodate the needs of the vast majority of patients. I think that would be the fair thing to say, but it's not tele-everything. Okay, Arizona program was started, as I said, by Bob Burns and myself, and a very key assistant director of the Joint Legislative Budget Committee, John Lee. And I had been a department chair for over 20 years at the time this came about. The dean of the medical school knew about my past background in telepathology before I relocated to Arizona in 1990, and asked me if I would take this on as a part-time job. And when I was in college, I worked in the US Congress, and I just kind of fell in love with working in state legislators or national legislators. I just thought that was the biggest hoot in the world. And so I have very fond memories of being in Congress and, and in high school, moved legislators and all that sort of stuff. So I think Steve has the greatest job in the world. But anyway, we started the program, created a logo, and got a state line, which still exists today, and kicked off the program. Now, what did the telemedicine program do? Well, this gives you a little more background. What were the three phases? Infrastructure, medical services, and training. There wasn't any broadband communication in Arizona. Two governors had failed, Symington and Rose Mumford had failed to get US West to be willing to come into the state. So there was zero broadband telecommunications except what the power companies own. And those were the only lines that exist. So that was crazy. And so basically there was an awareness that I had started a handful of companies. And so I think they threw a bone to the university. You guys think you're so smart. See what you can do about this. And so that was phase number one. Well, what happened? They threw the bone to us, and we thought it over, and we said, gee, if the utilities are being such a pain in the neck, why don't we just start our own utility? It'll be a quasi-utility, and we'll convince the university to house it. And we'll get risk management to think it's a great idea, because one lawyer who says, I'm afraid of it, would have killed the whole thing many times over. And they were great. I mean, I give the highest praise to our legal department at the university. And so we started this quasi-utility with the goal of wiring the state, because there just wasn't anything out there. Well, this is what it looks like. And Mike, if I can move this line down at the bottom so I can see the bottom. There I go. I got control. Okay, at the time we started, none of this existed. And the first T1 line that we got put in, first thing we did was created a corps of engineers like Mike Holcomb on the other end of the line. He's my lifeline. And we did it, and we put in a purchase order for a T1 line. So that was the kind of tube you had, the wire you had for broadband communications. And it was modest. We just wanted to do it between Tucson and Nogales, 70 miles. And it took us 18 months to get it installed. And we almost had to bring a suit against US West because they just dragged their butt so long. We were totally frustrated. But we figured out how to do that. And over the next 5 years or 6 years, this is what emerged. And we ended up with a network which today links 70 communities, 160 sites. About 60 subspecialties are done over the network. And it became a real magnet for federal funding. So since the beginning of our program, we've brought in about $40 million in federal grants. And so that's been a tremendous, given us a tremendous ability to innovate. So this is what this looked like about 10 years later. So, here, hey, we created a network, big deal. Who wants to use it? So we began working very early on, even at the Nogales stage, with our Department of Radiology. Now, the Department of Radiology at the University of Arizona actually is a very famous department. Actually, the American Board of Radiology is in Tucson. And so it's a very famous department. And the first digital subtraction angiography, was done here in 1973. So we had a department that was very into research, was very, very interested in teleradiology. So as we would put in each linkage, they would become the supplier of radiology services to that hospital, starting in 1998. And by 2002, we had linked to 25 hospitals. And in the year 2002, 2003, our Department of Radiology did 130,000 cases into 25 hospitals, mainly in Arizona, but then bleeding up into Nevada, where the Indian Health Service area extends. And that became so attractive that it attracted companies into the field. And the first major company was almost a clone of our program, and it was called Nighthawk. And today there are hundreds of teleradiology companies. So we have around 6,000 hospitals in the United States, and 85% of them have some form of teleradiology. 85% urban, and a lot of that's evenings and weekends, and then they're the ones for the PET scans and the one for the various kinds of scanners. So that's become a very large industry, so that came out. So phase number 2 was telemedicine services, show it can work. And once people get some kind of telemedicine, even if it's radiology or pathology, they tend to begin to say, what more can we do now that we've got this network in place? Okay, so now we have many sites and many communities, and we realize the next phase has to be to train healthcare professionals how to do telemedicine, ergo what I was talking about before. So we set about to become the hopefully the national leader in the area of telemedicine training, and that's what I'm going to spend the rest of the 10 minutes I'm going to use, or 8 minutes, talking about. Okay, where can you go for resources? You can go to our webpage, current events coming up, and there are a bunch of those and blogs that are coming up, and COVID-related things, and you can figure out the map of the state if you need a hotspot. But I want to talk about the training program and what they are. So the training program started in 2000. They come in 2 flavors, so there are 2 tracks that I'll describe in a moment. They're available. We waiver the $300 tuition for anybody from Arizona, and now we also waive it for anybody in our larger territory in the Southwest. But people from around the country come and pay the $300. So we have a site in Tucson, and then in Phoenix. In 2004, we got a federal earmark, and we're given the opportunity to create an e-classroom of the future, which, you know, I just love. I like to do that sort of stuff. I think architecture is fun. So basically, we were just putting the medical school in place there, and they didn't have a place to put us. They had these 3 ancient high school buildings that dated back to the time that Arizona became part of the Union, so 1912. So anyway, I talked to the leadership, and they said, well, you could have the area that's the balcony and the auditorium. So we did. We took that and ripped it out, National Historic Site, so we honored all those things. And we built the Classroom of the Future, which went on to win an international prize, first place international award for design of a facility. And so this is the facility, and from this view and from this view, and this would be linked to Tucson for these courses. Now, that's become a go-to video conferencing center, and last year there were 41 different organizations that use this facility. And you know, if ArMA needs a good video conferencing facility that would fit what you can do here, that's available to you. So there are lots of organizations that do it. So that was our facility. We put together a faculty. We have a distinguished faculty. We frequently bring in the best national experts when we do our training programs. We have 3 past presidents of national organizations on our faculty. We do give CME credit for the next 2 courses I'm going to describe, and that's at no charge. So let me quickly run through these just to finish up. So our standard courses are Track 1, Developing a Telemedicine Program, Clinical Services, Infrastructure, Distance Education, Evaluation, Business Aspects. And who do we like to have take these? And this is excellent for individuals who have some experience, right? Well, everybody on Ross's staff has experience. They've been doing it for 2 months now. I think anybody who's done a couple dozen cases would, you know, you want to have done something. So it demystify the whole thing. Also, individuals are interested in getting a deeper understanding of a growing industry, because there are many assets that you can bring to your program once you are doing telemedicine. And generally speaking, those are boom industries these days, and they're just worth knowing about. And so we go through a routine when we do that program, you know, 9 steps, and behind each of theirs, there would be a stack of PowerPoint slides. And it would be basically, if you went and asked a consulting firm to come in, you know, this would be the $10,000 consulting firm, but we offer that at no charge. Telemedicine applications is track number 2, and this gives a more in-depth view of what the applications are, and we focus on what the really important hot applications are, things like telestroke. In many parts of the country today, if you don't offer telestroke, that's below standard of care. So telestroke, pioneered, of course, at the Mayo Clinic in Scottsdale, has become a major national phenomena. So that would be one we would take a look at. We would look at telegeriatrics. We look at who's coming, and we invite the people in the state or in the region who are the top experts in that field to come and talk in these. So there's a general overview component to it, but there's also a component of looking at advanced applications. And these are about equally popular. And we've done these programs, as I said, since I think we've done over 100 versions of this. And there are many applications, and there are many things coming down the road that are worth knowing about. Here's a virtual hospital that exists as part of the Mercy system in the Midwest. And it's a virtual hospital because there are no patients. All there are areas where physicians in their 21 hospital network are doing telemedicine. Banner Healthcare with EICU, telecardiology, telestroke, as I said, has become a very big deal. And then direct to consumer has become just a mushrooming area, particularly in the last couple of years. And these practices are really worth looking at. The largest of them I'm told, have 50,000 providers in their networks, 50,000 providers. And those 50,000 providers are evenly split before MDs, DOs on the one hand, and nurse practitioners. So half nurse practitioners. And that's where the challenge to primary care is coming from. And where those people working from, I am told by senior executives in these companies that 99% are working from home. So, you know, it's really worth keeping an eye on these folks. And we can share what we know. So that's interesting. So those are those two, developing a program, telemedicine applications. So that's sort of the level 1 course that we do. Now, it's also an experience for a number of the attendees because half of the speakers are in Tucson, half of them are in Phoenix, and it flips back and forth. So you can examine your own experience in those two modalities sitting in the same room in the course of a day. And people get through that and they say, that's really pretty interesting to see the difference in the field because they're not the same environment. Regional courses are next. We've been doing regional courses for years. I really want to bring these again to ArMA's attention, because you've got doctors everywhere, of course. And these are a next level up course. So typically for these courses, we take some of the course stuff that I've talked about, but we add the next level up. So for this, we would bring in someone like Bart DeMarshall, who's the national expert in telestroke, or one of them, and of course he's at the Mayo Clinic, and he loves to come to these. Or we'll fly people in from other states. So it's a next level up. Think college courses 100, but then 300 level. This is 300 level, if you will. And those are done at single sites. Here, we did one in the most recent one we did off-site was in Show Low. Well, Show Low is a very interesting community. It has a new $100 million hotel or hospital, $100 million hospital. It has a new conference center. It has very sophisticated telemedicine. This was the grand opening of their new conference center. They were kind to invite us up to do that. And here we're more likely to talk about trends and hot topics in telehealth than we are to talk about the standard things. So it's really what's coming down the road. Here we spend a lot of resources and time always putting together our Reimbursement Roundtable. This is the expert from California flew in from it, expert from Georgia flew in for it. So we try to expose the people who take these courses to, you know, the best speakers they would hear nationally. Also, we like to do our regionals in areas where people are really, you know, pushing the envelope. So for example, they have an excellent telepain clinic service in Show Low. And they also have a dialysis center, which is serviced by telemedicine. So those experts come in and talk to us. And of course, they resonate within those areas because they're local phenomena within those areas. And then we've begun now taking them. So for this map of the telehealth resource centers here, we're in the Southwest, we're the TAN group, we share Nevada. And this is one we did last August up in Denver. And again, we mix and match to put together programs that would be most interesting for those environments. Okay, regional courses, just finishing up virtual courses. Well, like medical practices, we were forced to go virtual with our telemedicine courses, which had attracted, you know, roughly 50 people, usually 15 in Tucson and 25 in, or 35 in Phoenix. And we said, well, we're going to have to, so they would always be 50, right, 6 times a year. And so we said, well, let's just take our course and just see what happens if we put it on nationally. And we had 962 attendees. It exploded. We had over 1,300 registrants, and they were from 45 states and 11 countries. And when we look at the evaluations, matching same speaker in both presentations, ends up that they're statistically identical. So again, different experience, but it works well. And the last one that I want to bring to your attention are the partnered courses, because I think these would be a lot of opportunity to partner. And so let me just give you a specific example. So this was a partnering with the American College of Physicians, you know, huge organization with 100,000 plus members. And this was just a 1 hour thing. And really Ross's partner would be somebody who would be ideal to be in this kind, because he's in a position to tell what he went through to start up a program. So these really get into the very basics. So we did this actually as a 1 hour program, which was very successful. Ana Maria Lopez was our original medical director. She's now in Jefferson Medical College in Philadelphia, but she's the outgoing president of the American College of Physicians. And these were three, I think they were all on their board of governors, but here was a guy who had just started a practice a couple of months ago and told, you know, gave people a very straightforward presentation on what's going on. Bottom line is, was successful. She was a real expert on interacting with patients. How do you actually create the best environment to interact with a patient using telemedicine? A surgeon who gave us a surgeon's perspective on picking platforms. You know, it was a great hour. And so for these kinds of programs, they make a great partnership between what we have as assets and what you're interested in offering your members. And we're getting a lot of interest in these programs. And certainly, you know, frankly, we would always have the Arizona Medical Association right up on the top of our priorities. Okay, the last thing that I'm going to mention is the service provider directory. Our service provider directory was started about 5 years ago with, again, federal funding. There are many companies that are offering services directly into hospitals. So these are direct to hospital services. A lot of them are whiteboarded, where Tucson Medical Center, it's under their brand, but all the doctors are actually coming. That's all being outsourced for some of these types of services. And, you know, how can somebody in one of our hospitals actually shop that market? And so we decided we would provide a directory that would be like a mall, that people in a couple of hours could put into a relational database, you know, where they're from and what they're interested, what they're looking for, and the names of companies pop up that actually do those. And this has become so popular, this directory is now in the toolkit for both HHS and CMS as sites to go to as a reference. And we're the biggest in that area. And I'm just going to end up with a video that quickly describes what that's about.
Looking for clinical services to extend the reach of your organization and improve access to care? Using telehealth technology, you can bring an array of healthcare providers to your patients and avoid having to refer them out of your system. The National Telemedicine and Telehealth Service Provider Directory makes it easy for you to find the teleservices you need. Our focus is on services that interact with the patient from a distance, not on platforms, apps, technology, telecom, consultants, or back-office services. To find the directory from the Arizona Telemedicine Program website, go to Featured Links and click on the first item, Service Provider Directory. The directory is searchable by state or states where you need services, by teleservice or services you're looking for, by the type of organization you are, and by any ancillary patient services you may need. Once you've chosen your search criteria, the directory does your research for you. You'll see a list of service provider dashboards that you can quickly compare. To see more details about any listing that interests you, simply click for Full Details. The Full Details page contains a wealth of information to help you compare apples to apples and decide which service providers are likely to best fit your needs. Once you've compared the full details of your service provider candidates, you can find out more. From the Full Details page, you can go to the company's website or get in touch with them directly using the contact information provided. Thanks for using the National Telemedicine and Telehealth Service Provider Directory. The Telemedicine and Telehealth Service Provider Directory is a public service of the Arizona Telemedicine Program and Southwest Telehealth Resource Center.
And there's no charge to be listed in the directory. But we check once a year to make sure you're still alive and well. And so that's our number one criteria. Okay, well that's my story, Ross and Damien, and be delighted to answer questions.
Thank you, Dr. Weinstein. Yeah, we'll go ahead and jump right into some questions here. One submitted prior to tonight. We have made great strides in telemedicine in a relatively short period of time. How do we make sure those strides are maintained after the public health emergency ends?
Well, we get on the phone with Steve and we say, hey, Steve, help. So, you know, hopefully there's enough pressure to have CMS take and make their waivers permanent. I think that's probably the most important thing. You know, for a long time, CMS lagged way behind the Medicares, and also for parity legislation. You know, you have to do it if you can do it, or parity reimbursement legislation. You have to pay the same amount, right? And so the states and Arizona, to its great credit, our Medicaid was way out in front of a lot of other states in taking leadership roles in creating the billing codes. And, you know, I personally have nothing but good things to say about Medicaid and their diligence in actually doing this. But Medicare, and the problem with Medicare is that CMS had to have a piece of federal legislation for every new billing code, right? And basically we would go, you know, past president of the American Telemedicine Association, we would go there and pound on doors on the Hill, and they would parse out one or two a year. And you would say, is this actually going to happen in my lifetime? This came along and all of a sudden 80 to 85 new billing codes were introduced overnight. You know, roughly 40 years worth. So the question is how is that made permanent? And the sense is with the enormous utilization and the very limited pushback that's taking place by people who put it in their program, that would be enough to force the issue. Now, can you get anything through the federal legislature this day? I mean, that's a whole other bad story. But I think that's the story. You know, I think that our legislature is very receptive. I think our Medicaid is receptive. I'm not making a plug for any particular person, but I'll tell you, Senator Heather Carter has been wonderful in galvanizing the reimbursement world, and she's done miracles. And other people are way up on the list as well. So I think, but I think the docs, I mean, I hope that ArMA can play a role in encouraging our state government to keep waivers that are enabling in place. And hopefully we're beyond the tipping point, which I think is probably the case.
Dr. Weinstein, Steve Barclay here. First of all, thank you for an extremely informative presentation. I always learn so much from you, and tonight is no exception. I would add that I agree with you that a lot of it's driven by CMS as the big payer that I think will cause the insurance companies to turn their battleships around. But the governor, to his credit, did an executive order 2020-15 to expand telemedicine during the COVID-19 pandemic. And that, I think, you know, charts the course for the state legislature to expand and build on what they've put into place over the years. It's been piecemeal, but we essentially have a parity of coverage that kicks in effective 1/1 of 2021. So we need to bridge the gap till that. And then I think we need to work, redouble our efforts to make sure that the language is expanded to include things like parity of payment, to also include things like telephone only and other instances where you have limitations on internet and connectivity that are impeding the ability of both the patients and the physicians to use the telemedicine services. But I think the pathway has been charted. We just have to set off on that course.
Yeah, we were just delighted with the steps that the governor took, and you know, he was really way out in front of a lot of governors and really understood the issue. And he's been a very willing student, and people can talk to him, and I think he understands the issues. And so much to be proud of in terms of who we have in our government, certainly with respect to this. And I think that to keep the pressure on it, because it could drift back, and there's the point at which practitioners are going to have to come out and say, this is fine with us. Please let us keep doing it.
Jamie, if I could chime in also, I've got a couple comments. Again, this was an excellent presentation. I can talk a little bit state and federal, actually, just with the variety of activities I'm involved with. Just to let everyone on the call know that we at ArMA actually have a monthly call with all the insurance companies in the state. We just had one last week. Blue Cross, Aetna, Cigna, United, Access, Governor's Office, everyone on this town hall. We all had a conversation about, and just to answer a couple of other questions that popped up in the chat too, there's this new concern about end dates being brought up. Steve brought up the executive order. The executive order doesn't end until the state of emergency is taken away. And we've been told multiple times that it's not going away anytime soon. So whatever end date you hear about June, unless the executive order is taken down, that's not going away. And the insurance companies recognized that and acknowledged that last week and said it's a moving target. That they put them out there as kind of a stopgap, but they understand that if, we're in July and still in the state of emergency, and it was made quite clearly on the call that that's probably going to be the state we're in, no matter what else is going on. So things will continue, which gives up an opportunity to work forward. And ArMA, we've already started to have that conversation internally, and actually with with one in particular, Blue Cross has reached out to us as we've reached out to them, talking about what is this going to look like when all this is over. So we have a very rare opportunity to get ahead. I said this, I think, last time too, a little bit, that it's a rare opportunity to really kind of lay the groundwork. So we want to make sure we have that role. On the federal level, I'm involved with the American College of Surgeons, among other organizations. And I can tell you for certainty that a conversation is going very hard about telemedicine on multiple levels with Congress. That is discussed at numerous levels. I sit with the advocacy group for the American College of Surgeons, so I get updated. We are in deep conversations with the White House and legislature about what needs to be done and what the future of telemedicine will look like. It's not going away. I just want to emphasize to everyone on the call that we need to make sure that we're in the middle of this discussion. Otherwise, it'll get done to us, not with us. I'm done.
Well, I think those are great comments, Ross, and it's very good news. We're certainly there, and any point at which you would benefit from having national leaders in the telemedicine field, whatever specialty, come with you to Washington. That's easily arranged. We have very good strength on the East Coast. And anytime that we can help you in Phoenix, we'll hop in the car and come up. We realize that, pressing the flesh is critically important. So I think that we can be available and feel that that's a ready resource.
Well, I can tell you is that we always welcome volunteers, and we thank you in advance because now we'll definitely take you up on it.
We will.
Fantastic. I think this next question we got live really builds on what we were talking about. So last week, the industry representatives spoke to the patient perception that telehealth should be delivered at a lower cost. Yet the experience with the viability of telehealth is that a key part of the current success we're seeing is the equal reimbursement, the pay parity. So what are your opinions about the opportunity to move the needle up on reimbursement for telehealth in the future?
Yeah, well, I think that's a very important point. And I think it was touched on last week in terms of, but the back office expenses don't go away. We're just talking about when the patient's in the room, right? And so the back office expenses are there, and the telecommunication expenses are there. Telemedicine is not cheap to do. Telemedicine often means that your personnel overhead actually goes up. And I think that, and in certain fields, it goes up quite significantly. For example, you would not do a telepsychiatry case presentation without a case manager in the room with the patient. What if it goes sour? I mean, you just need somebody right there. So we have to educate the public that there is an infrastructure, just as there is for a television station and any kind of an information system. So what you see is just part of what you get. And we're currently doing federally funded studies on that point and can provide real cost information on clinical trials that we actually are part of. And you could discuss those with you offline.
And this also too is the value that we need to show for the convenience factor for companies, for our employees, employers. One example I remember is one of my colleagues did a surgical eval. Now we're not examining them, but an initial screening, and the person never left work. They were on a break. So they literally were at work, they took a break, and I work at the county facility, so our patients really, they rely on these jobs to keep going, and they can't just take time off. It's a big deal to come see the doctor for a day. It requires loss of income a lot of the time for many people. So they can literally take a break, call, have a 20-minute conversation about their hernia, their gallbladder, so we can start talking about it, and then went right back to work. They really enjoyed it. Now that convenience though comes with a cost, and I think we need to find a way to, how do we make that valuable and put a dollar to it? It's tough to do because it's very theoretical for lots of people, but that's the argument we're going to have to bring, is everything that comes along with it, the convenience. The term I've been using recently is no one wants to know how the sausage is made, they just want it. But we've got to educate about how much goes into making the sausage.
Dr. Goldberg, speaking of sausage, on the public policy side of things, the toughest nut to crack has always been getting into the area of legislation that would set rates or reimbursement. That's oftentimes a bridge too far, particularly among Republicans. I think what we can achieve is parity of payment between what's paid for the same visit in an in-person visit and what's paid through a telemedicine encounter. I think it's that kind of parity that is achievable even with a Republican-controlled legislature.
And I think it's worth noting that looking at putting new technologies in place and evaluating their value, the federal government and a quasi-federal organization called PCORI are spending a fortune on that kind of research. So for research that involves taking practice models to another level, this year more money will be spent on that kind of research. Not necessarily telemedicine, but across the board. More money spent than is on stem cell research. This year, the NIH budget's about $1.5 billion for research on making things practical and studying what they're worth. And we're very tied into that. And the PCORI grants actually are an independent organization that gets their funding directly from the U.S. Congress to do that as well. And so lots of information is coming out, and the question is, but that's academic. The question is, how do we get it to Ross, and how do we get it to Steve in ways that is meaningful and useful to you? But it's no longer in large academic medical centers. It's actually going out into the community to do these kinds of studies.
Great, thank you. We're going to finish off with one last question from the audience before we wrap up everything. Given the many years of telemedicine in retrospect, what was the biggest hurdle you faced that prevented where we are now? And then do you have any battle wounds to go with that experience?
Oh, I don't have battle wounds. I'm glad to be working, but I enjoy it. To me, being a physician is such a great joy in life. I think that, no questions, reimbursement. That's why it all fell apart in 1980. So I mentioned before the Western Governors Association with this classic study, and so this was 93, 94. Now, our Western Governors Association is the top governors association in the country going away, right? So they started the Western Governors University, which is, the second largest producer of primary care teachers in the world. They've done a lot of great things, and they decided to get and take a look at this, and they finished it up, and they wrote a very good document, which they published in 1994, and it identified policy, regulation, reimbursement as culture, and maybe the concerns about safety and malpractice. That disappeared. The first 20 million telemedicine cases didn't have a single case that went to a jury. Safety is not the issue, but culture, we can certainly address those issues. But policy, regulation, and reimbursement, and a great deal was done on policy. A great deal was done on regulation. It was set to go, and there's no question that the barrier was reimbursement, right? And that's what COVID took out of place. Now, we would never have imagined an academic study would say, well, the first thing we're going to do is take 90% of the population and lock them up for a month and see if they use telemedicine before. I mean, I don't think that go through our institutional review board too easily. But that's the experiment that got done. It happened to be a tragic experiment of nature, but that's what got done. And it was about reimbursement. And it turns out that everything else falls in line. So that is the issue. And to get that parity legislation for reimbursement through is really important. And it gives us the opportunity to articulate our reasons in a public forum, which ends up being public hearings. And, you know, we really want to take the lead in doing that in the state. Now, there are roughly 12 states that have parity legislation for reimbursement, so we're not starting from scratch. There are over 30 states that have just, you know, parity reimbursement generally. So we're going into the majority. And when we got involved with the Representative Burns, after we'd been working together for a couple of years, I said to him, you know, who's going to write the legislation? He says, well, you look at the adjacent states that have a governor with the same party, and we call it model legislation. He says, so you go out and find me in the adjacent states where they've already passed legislation, and you find me the staff person who succeeded in getting that through the legislature, and I want to talk to that person myself. And we've done that on a number of occasions. So because we do have this large national network, we can find out, and we do have a center specifically for legal affairs that covers the whole country. You know, we can find out who that person is in that legislature who might help us. Now, I don't know if that helps, Steve, but you know, there are people who've been through it, taken the wounds, and probably can help us out in terms of wording the legislation where we can actually cite adjacent states with which we're friendly.
I think that helps greatly. Thank you.
Great. Let me just get my screen back up here so I can share one last slide with everybody. Just as a quick recap for all, the town hall tonight was recorded and will be published on ArMA's YouTube channel in the following days. If you do have any further questions, I know we've got a great line of communication with Dr. Weinstein, and we'd be happy to share any questions you may have. So feel free to email us at the communications@azmed.org. Resources are available. Just a quick reminder about the resources on ArMA's website regarding telemedicine, especially COVID-19 resources. There's an FAQ as well as COVID-19 financial resources. And with that, we would like to thank Dr. Weinstein for his time and to thank you all for joining us this evening. We hope you have a good rest of your night.
Bye-bye, everybody.
Thank you.